Good afternoon, everyone, and welcome to the second session of Children's Week. My name is Dr. Ruth Adewuya. I'm the Managing Director for the Stanford Center for Continuing Medical Education. Today, the session is titled Wet Again, Approaches to Pediatric Urinary Incontinence. Just a few housekeeping items for you as we get started. We will be asking you to put your questions for our speakers using the Q&A function in your Zoom. So if you look at the bottom of your screen, there will be a Q&A button there. Feel free to put your questions in at any time, and there will be dedicated time for the speakers to respond to those questions. Today, I am pleased to introduce our speakers. Sarah Oppenheim is a pediatric nurse practitioner at the Lucile Packard's Children's Hospital. She is a Bay Area native who completed undergraduate studies at UC Berkeley and graduate pediatric nursing training at UCSF. She is a board-certified pediatric nurse practitioner who has been working at Stanford Children's Health, the pediatric urology team, since 2014. And she covers ambulatory, inpatient, and operative services at our satellite clinic sites in San Francisco, at CPMC, and in Walnut Creek at John Muir Medical Center. Joining her is Dr. Bill Kennedy, who is a professor and the chief of pediatric urology at Lucile Packard Children's Hospital. Dr. Kennedy began his faculty career at the Stanford University School of Medicine and Lucile Packard Children's Hospital in 1997. Among his many current leadership positions at Stanford, Dr. Kennedy is the chair of the Finance Committee for the Pediatric and Obstetrical Faculty Practice Organization, Associate Chief Medical Officer of Stanford Children's Health Alliance, let me restate that, Associate Chief Medical Officer of Stanford Children's Health, and the inaugural chair of the Board of Directors of the Packard's Children's Health Alliance. Dr. Kennedy has published over 32 peer-reviewed articles, 19 book chapters, and 1 book. He's a section editor and manuscript review consultant for several professional journals. He is a nationally known lecturer and has been honored by organizations for his teaching, research, and clinical accomplishments. And so I'm really pleased that they are joining us today to go over this very important topic, and I will turn it over to them.
Great, thank you, Ruth. Let's make sure I have the slides up here to start with, and I think we are good. All right, well, welcome everyone to our session on urinary incontinence. First order of business is our disclosures. Neither Sarah nor I have stock in any companies or own anything that pertains to Eneresis. And then the other is just our goals for the lecture today. And what we'd like to do is help you to achieve 3 major points. One is identify children with voiding dysfunction and elimination in your practice, to teach you how to initiate the basic workup and provide first-line treatment for children with voiding dysfunction. And then the second is to identify and provide first-line treatment for children with primary nocturnal Euresis. The way we'll go ahead and set up our lecture for this afternoon is to first go over some information on dysfunctional voiding, teach you how to identify it, what the basic skills are for starting treatment, and then Sarah will join in and present 2 cases on that topic. Then we'll move to primary nocturnal Euresis, again, go over some of the information that's essential to diagnosing and setting up the elements of first-line therapy. And then Sarah will then join in and do 2 cases on primary nocturnal Euresis. Sarah's one of our nurse practitioners who does a lot of the counseling for these children and first-line treatment for them. So she's really the expert when it comes to the therapy, and so happy that we have her here today to help out in this presentation. First, what we'll do is just go over some of the definitions that everyone just needs to be aware of, because the word Euresis doesn't always mean the same thing, and some of the adjectives beforehand are actually helpful. Nocturnal Euresis obviously is just nighttime incontinence. Diurnal Euresis is daytime incontinence. Primary enuresis will be a child who's never actually had an extended period of dryness. And secondary enuresis is when the onset of incontinence comes after a period of dryness. And that period of dryness would be considered about 3 months or greater. So that's how we'll use those terms as we go through the presentations today. So the first issue that I'd just like to bring up is, what is the anticipated age of urinary control? And by US standards, because it can vary culturally in different parts of the world, the age of 4 is when most children develop what we would call an adult pattern of urinary control, and that's achieving both continence during the day and continence at night. When a child is younger and just born, bladder function in infants is characterized by instability, and their bladder contracts multiple frequent times throughout the day, and it's done so by an unsupervised spinal cord reflex. So they have absolutely no control, and many parents in the audience there will know you can just put a fresh diaper on a child, and 10 minutes later, the blue stripe is on the front signaling that it's wet, because they can frequently void within an hour each day. So healthy infants void regularly and usually within an hourly interval. And when they empty the bladder, it's not complete, or is it coordinated. In boys, it's even more uncoordinated than girls. It frequently will take them 2 or 3 voids to empty the bladder. And residuals after they empty the bladder can be as high as 30%. So that's the standard pattern that we're working with as we move on into the period when children are trying to gain control. And what are the 2 necessary elements to start urinary control? And I show you here a picture of a cystogram of a bladder. Not that we do cystograms on every child as they approach potty training age, but I think it actually shows you what we're looking for. And that's, do they have appropriate capacity of the bladder to maintain a period of dryness, probably for about 1.5 to 2 hours as we start the period of potty training, and that they also have control of the voluntary external sphincter. And the voluntary external sphincter is, let me see if I got can you see my pointer there, hopefully, is located right about here. And that's where a child will tighten up in order to stop the process of voiding. And that's the first willful thing that they need to recognize in order to stay dry. Oops, let's see. We'll advance here. So in order to develop urinary control, a child has to successfully have a bladder capacity that increases. They have to learn the voluntary control over the external sphincter, which most of the time for boys and girls happens at about the age of 3. And then ultimately, to get to the sophisticated part of potty training, they have to be able to volitionally control the spinal reflex, which controls a detrusor or a smooth muscles that are very hard to influence. And this is when you can ask a child, can you go to the bathroom? And they can do some things to initiate voiding. Generally, urinary control comes earlier in girls and boys. And here in the United States, we sort of target for girls, usually 2 to 2.5 as the average age of potty training. And boys, it's almost a year later because of issues with that discoordination of the muscle of the bladder and the muscle of the sphincter. And they are generally potty training at about 3 to 3.5 years of age. There are some external influences that kind of can change those ages, and siblings that are a little bit older tend to be role models for younger siblings. So those children might potty train a little bit quicker. Frequently, children who are in daycare or other group activities during the day tend to be a little bit earlier with potty training as well. Single children at home, not interacting with brothers or sisters, tend to be a little bit more on the lengthier end of the spectrum. And this is just a pictorial for some of those things associated with learning to potty training. In the first picture, you can see the detrusor muscle is actually the bladder itself, and that is the involuntary muscle. And then the sphincter muscle sits just below the bladder neck, which is this area. And that's the one where we have willful control over to prevent wetting ourselves. And you can see that when the child first gets the signal that they have to urinate, the bladder neck starts to open and they close the external sphincter muscle or tighten it up to stay dry while they get to the restroom. And when they get there, then they relax. You can see in the second frame here by the green arrows, the external sphincter muscle, and then the bladder starts to empty. And a child who has normal voiding will keep that sphincter muscle open the entire time that they're voiding, and they'll empty the bladder to near completion. So what is dysfunctional voiding or dysfunctional elimination? And this is the most common cause of daytime urinary incontinence in children who have previously had urinary control. And it's a symptom complex and has many different names and many different features to it. And some of the things that Sarah will go over in the case study are how to identify some of these factors that kind of give you the diagnosis of dysfunctional voiding or dysfunctional elimination. And the first is it can be as mild as just some dampness on the undergarment, or it can be severe daytime frequency where a child might even go through bouts of having to urinate every 15 minutes to half an hour. It can be just some daytime wetness, or it can be isolated nighttime wetness that's come on in a secondary fashion. It can be associated with encopresis and very, very frequently with constipation. So oftentimes the parents are coming to you and they're wanting to tell you about their wetness problem, but you really need to also dig into their history of bowel habits because that can so influence the ability to stay dry. It can also be associated with urinary tract infections, and we'll go over that in a little bit more detail. And then in the very extreme cases, we can see hydronephrosis on ultrasounds. We can even see vesicoureteral reflux as a new onset phenomena because they're holding on so kind of severely that they mount pressures in the bladder, which blows out the junctions of the ureters to the bladder and causes reflux. And in very rare situations, we can even see children go on to renal failure as a result of dysfunctional voiding. Some of the other common names that we see tacked on to very specific types of dysfunctional elimination, we can hear it called overactive bladder syndrome. Usually it starts as an infrequent voiding syndrome because the children want to really participate in all games and activities and start with the postponement of urination for their own social good. And that's a plan that backfires on them and frequently will start the dysfunctional elimination. Giggle incontinence is a form of a dysfunctional elimination syndrome. Daytime urinary frequency, post-void dribbling, and even some nocturnal enuresis alone can be dysfunctional voiding. And we'll go over a little bit later how to differentiate nighttime wetness that's dysfunctional versus nighttime wetness that's primary nocturnal enuresis. And it's usually the secondary nighttime wetness is associated with dysfunctional elimination. I think one of my favorite pictures was one that I took about 25 years ago when visiting Legoland. And I think Legoland got it right. I mean, when you look at their signs for the bathrooms for young children, you can see typically that they're recognizing when kids are active, excited about what they're doing at an amusement park, other activities at the playground, computers, video games and such, they become dysfunctional and they don't want to go to the bathroom. And you can see the children in this sign here are posturing in a way that they're recruiting muscles to prevent going to the bathroom by tightening up their pelvic floor. And commonly we call this the potty dancing, and we'll go over what they're doing at that point as we get to some of the diagnostics. Other things as we go ahead and see a patient with dysfunctional elimination in clinic is we want to go over some of their social history, and some of the things that we want to put on the list to ask about are some social and medical factors that can put them in higher risk for dysfunctional elimination. There have been many studies published out there that show that ADHD is associated with higher risk for dysfunctional elimination. Also, children with hyperactivity and general anxiety often are kind of really type A personalities, have been shown to be associated with more dysfunctional elimination. And one of the greatest factors are strained family and social relationships. And I've listed several here: divorce or separation of parents, significant loss, death of a family member, new siblings, home moving, new schools. Those are significant social factors in a child's life that can influence their voiding habits. In the urologic history, we want to ask about their present voiding habits, frequency of going to the bathroom. Do they have urgency where they all of a sudden have to drop and run really quickly to the bathroom? And do they have wetness on their undergarments? And frequently we want to evaluate, well, what has been their toilet training history. These children with dysfunctional elimination generally tend to be potty trained on the earlier end of the spectrum. It tends to be an easy process for them because they learn how to gain control over the sphincter, and then they gain control for their social benefit of postponement so that they can continue with activities that they find more fun. And here you see a picture of two postures that are very common in children who have dysfunctional elimination. The first we typically call the potty dancing, where they kind of cross the legs, wiggle around, and they're recruiting pelvic floor muscles to reinforce the tightening of the external sphincter so that they don't leak as they're getting the sensation to go to the bathroom. And they usually do that until the detrusor muscle just gives up, stops squeezing. And then at that point, the urge goes away and they resume activities and continue about. And maybe another 15 minutes later, you'll see the same posture. And parents are really good about recognizing this potty training and say, well, don't you have to go to the bathroom? And then after they're finished with their little dance, they say no, because the detrusor muscle starts squeezing. And then lo and behold, 15 minutes later, they have to go again. The other picture you see is a young lady who's squatting down and kind of has one foot pushed up against the pelvis. And this is a typical posturing that they call a Vincent's curtsy. And what's believed to be happening is that when the child squats down, they're recruiting extra pelvic floor muscles, but the young girl is also pushing her heel of her foot into the pelvis, almost to compress the urethra against the pubic symphysis to prevent wetting. And that's where this posturing comes from. Boys do the same, but they don't have to squat. They just grab at their penis and squeeze it. And lots of parents will tell you, oh gosh, she's always doing that. And it's usually a sign that they need to urinate as well. Other things in the urinary history is we want to kind of talk about whether or not they have neurological problems that lead to some dysfunctional voiding. And these are the children that have never gained urinary continence. So if we have a period of 3 months of dryness before wetness starts again, that's the child that falls into dysfunctional elimination. If they're 5 years of age and have never had daytime wetness, then we need to approach them slightly differently and start to look on their physical exam or their signs of other neurologic problems that we need to take into account. Other things we want to ask for in the urinary history: do they have urinary tract infections? And the UTIs associated with dysfunctional voiding is a sort of difficult situation because it's the proverbial question of which comes first, the chicken or the egg. Sometimes a urinary tract infection can be so bad that it then triggers the child in the post-infection period to have developed dysfunctional tendencies, largely because they've learned this talent of now tightening up and not going to the bathroom because it was so painful during the infection. The other issue with dysfunctional voiding is that it puts you at higher risk for infections because you're generating a high pressure in the bladder. You also, as it comes time to relax, are relaxing inefficiently and sometimes sporadically, so you have large residuals, which can lead to urinary tract infections. So teasing the two apart is sometimes difficult, but oftentimes you'll see an association of UTIs with dysfunctional voiding. On physical exam, grossly it's normal. There aren't many findings for dysfunctional eliminator, but some of the things that you might want to be looking for are when you palpate them, is there a distended bladder? So you're going to be palpating below the umbilicus and up to the pubic symphysis, and do you feel a bulge there? Or even just looking from the side, can you see a contour abnormality there? The other is looking for impacted stool. Obviously, if they're an adult, you could do a rectal exam. Most kids, we don't do that. But if you palpate in the left lower quadrant, especially in a thinner child, you can often feel some of the very, very significant stool that's backed up into the sigmoid or descending colon. And then you want to be particularly careful about the neurologic aspects of your exam, lower extremities, also looking at situations around anal sphincter. Does it appear to be looser than norm? Is there soiling on their clothes? Now, diagnostic tests, you'll see a long list here. And that long list are things that we can do to evaluate dysfunctional voiding. But the big question is, should we do them all? And we always want to make the intensity of our evaluation and diagnostic tests to actually parallel with the severity of symptoms and the degree of dysfunction. So in the early phases of the evaluation, we're just going to be concentrating on a couple of simple tests. But if we're embarked on treatment, a child's not getting better, we might consider escalating some of the diagnostics. And I'll run through the different tests that we have listed here and kind of share with you when I think they're helpful, when they might be of use in setting up a treatment strategy. So the first is ultrasonography. And with ultrasonography, any child who's had a period of dryness and then starts a period of wetness, we want to go ahead and get at least a simple ultrasound for them with daytime wetness. And what we're looking for here is, do they have signs of hydronephrosis or hydroureteronephrosis? We want to also look at the bladder wall, see if it's particularly thickened. And we also want to sort of assess, well, how much does the bladder hold at their full volume, and what is the residual afterwards, to see if there are large residuals. And these can be important factors in determining where we want to go with our treatment strategy. And here you can see a picture of an ultrasound that we've done on a child with dysfunctional voiding. And you notice here the two yellow arrows show the thickness of the detrusor muscle, and it shows a moderate residual left in the bladder. And this is important to us because this might be a child who's going to take a little bit longer to get over the dysfunctional voiding by having a detrusor muscle that's already hypertrophied or thickened. And oftentimes this is a child who, after we start behavioral therapy, if they're not responding, we might even consider, do we add an anticholinergic to their treatment regimen? And then also the post-void residual might help us to fine-tune some of the behavioral elements of our treatment for them. Abdominal X-ray, any child who has irregular bowel habits, constipation, encopresis is one that we might want to go ahead and do an ultrasound on. And here we're testing for fecal retention. Here you can see some pictures of children with primary wetness during the day, and the parents saying, well, you know, we don't really think that they have a problem with bowel movements. They seem to be going every day. And then when you ask the child the same question, you get, well, maybe I go once or twice a week, and the parent is just in total disbelief that that's the case. And here's where an X-ray might be helpful. And you can see in the standard abdominal X-ray upright that there is stool throughout all of the descending colon, across the transverse colon, and down the ascending colon here. And we can see the rock hard boulders inside the sigmoid colon there. And then the other picture I show here is a CT scan. And the CT scan is one that was really prominent for excessive retention of stool. This was a child whose parents brought them into the emergency room because they thought they had a new onset of a mass in their lower abdomen. And so they went right to a CT scan to look for an oncologic reason. And what they found here, circled in the red, is the sigmoid colon just so impacted with stool. And you can see the yellow rim here, that's the bladder with the contrast pushed over to the side. So you can truly see how the relationship of constipation has a significant impact on the bladder and the bladder function. And frequently when children come in to an emergency room with urinary retention, one of the primary reasons for retention is actually constipation. And it's always in our differential as we see children. There we go. VCUG, when do we kind of recommend VCUGs? VCUGs are actually helpful in children who have had significant daytime incontinence, as well as a history of febrile urinary tract infections, and especially febrile urinary tract infections that have been difficult to treat, taken many days for temperatures to go down. That hints that potentially it was a pyelonephritis rather than just a cystitis. And this is where a VCUG would be handy. It helps us out with the bladder capacity question. It tells us a little bit about bladder appearance and also answers the question of, is there vesicoureteral reflux, which might put them at risk. And these are the children that can spiral into renal failure if not protected during the time of treatment. And here you can see a classic fluoroscopic VCUG. So this is done with X-ray technology. And the terminology in the past that was used when we only did fluoroscopic VCUGs was a spinning top configuration. Most children nowadays don't know what spinning tops are because it's not a digital based game, but you can see here the bladder, and then this is the dilated urethra as a result of the tightening of the external sphincter down low. The bladder neck is open here, and then the urethra starts to dilate here. You can see that the turbulence created by this dysfunctional voiding also allows urine to track into the vaginal area. So sometimes the incontinence comes from vaginal voiding in young girls. It's also a nidus for infections and dampness in that region as well. Here's another VCUG that was done for dysfunctional voiding. And here what you notice is that we don't have that smooth wall bladder that we saw in the last picture, but the bladder is very what we call trabeculated or irregular in its shape. And this is an excessively thickened bladder wall that creates an appearance like that. And these are the children that frequently will need, in addition to just behavioral modification, some of the anticholinergics to try to control that muscle as we work more on their behavior. Office uroflorimetry, this is only something that children who are referred to a urologic specialist will have done. And these are devices which help us out with determining functional bladder capacity, what their post-void residual is, and if they have that dyssynergy or discoordinated sphincter muscle. Generally, the device is set up in a standard restroom. We don't have them go to the toilet in the regular toilet, but into what is a bedside commode apparatus. And you can see at the bottom of that, there's a collection device that actually records the way that they're urinating. And the flow pattern is sent to a computer. And then afterwards, we use ultrasound technology to determine what their residual is. And here you can see the normal pattern for a child who goes to the bathroom. It's that kind of nice biologic phenomena of a bell-shaped curve that we like to see. And it means that the child tightens up, but when they get to the bathroom, they finally relax. The detrusor muscle allows the urine to come out really smoothly, and then they lose a little bit of velocity as they get to the very end and they finish. In a child who has dysfunctional voiding, that pattern might be very different. And we call this either a mountain range or a staccato-like pattern. And what you're seeing here is that they initiate void and then they stop suddenly because their sphincter contracts. Then they finally relax and more comes out and they contract. And this leads to both a lengthier voiding process and ends up being a premature termination before the bladder is finished, and it reinforces that tightness of the pelvic floor. Urodynamic studies, this is the studies that are done when we've embarked on treatment, have tried just about everything, and we're still not getting a response, and we need a lot more complex physiologic information from the bladder. And to do these tests is very invasive. They need a catheter in the urethra, catheter in the rectal area to monitor abdominal pressures, and little patch electrodes. And what we get from a urodynamic study is a comprehensive evaluation of the bladder. We can both see what the bladder looks like, we can time events, we can see when the bladder is contracting here in the first phase, we can see how the sphincter muscle is relaxing or tightening up in the voiding. And this is the flow here. And then the last is the EMG of the sphincter muscle. We can see it's tightening or discoordinated at the time that they're urinating. We can see when they start to relax, we get these bursts of urine coming out. And this can lead us to devising a very, very precise plan of treatment, but we don't want to always go to an invasive test because many of the items that we find out by history and some of the simple diagnostics can very effectively start a treatment plan for a child. Well, how do we go about treatment for these children? I wish it were as easy as training a dog. We'd love a solution where we could just put a post in the ground and tell them go for it, but it's not that simple. The basic principles of therapy, and Sarah will go over these in some of the cases, are first to intervene with behavior, because behavior is the key to the entire process. We've got to establish a regular voiding schedule. And then if they do have recurrent infections, we have to tone down the infection so we can gain control of the bladder. If they have constipation, we've got to factor that in the treatment plan as well. And then depending on what progress they're making, sometimes we have to rein the bladder in with the use of medications. But we never want to do that at the start, because if we do start with medications, they might not ever change the behavior. And every time we come off the medications, we're just bound for a relapse. Some of the principles of the timed voiding for behavior is to develop a regular and frequent schedule to go to the bathroom. We can use lots of adjuncts to help someone out. There are watches that you can wear. There are timers you can set on your cell phones. The thing that I like best is to try to walk through a regular day with them, like a 9 to 5 sort of process of school day, and try to set expectations for voiding and time them to events that regularly happen during the day. We can all gain alarm fatigue after a while, and the things that work great at the start with cell alarms or with watches sometimes breaks down after a month or two, but daily events happen every day for many years in a row. And if we can get into a timed schedule based on events, I think we have the long-term success there. We often will go ahead and give them a sheet of paper, but people have set up elaborate computer diaries and other things, but just something to keep track of when they're going and to sort of report back whether or not they've been wet or dry. And frequently in just a little graphic like this, most of them put stickers or stars when they achieve things. You can actually see the progression of a 4 to 6 week period of improvement with behavior modification. If we've had no improvement over that initial 4 to 6 weeks, that's when we start to think about escalating to medications. But behavior is the key to improving these situations. We've got to give them some tips for how to go to the bathroom. One of them is double voiding, because lots of them have high post-void residuals. So we'll tell them to urinate once, relax, continue on the potty for a little bit, maybe bring some activity in with them and try a second time so they can get out the higher residual, which frequently is leading them to infections. Removing garments completely is very important, especially for young girls who are sitting on the toilet, because most of the time they're in such a rush, they pull the garment down to their knees, which actually pulls their knees in and tightens up their external pelvic floor and sphincter and makes it harder. So we want them to take garments off all the way, especially at home. We don't want to do that in the school setting because we don't want to set them up for doing something very different than their peers. But if they can practice that relaxed posture at home, it often carries through to the day at school. Another simple trick to get them to relax their pelvic floor if they're having trouble is at home, tell them to sit on the potty in the reverse direction, because that forces the legs open so that they can relax the pelvic floor, and they get a sense in a simple way of what is a relaxed pelvic floor and how much better the urine flows in that position. Treatment of constipation is very, very important. And here are some of the standard things: the increased fluid consumption, high fiber, mineral oil, laxatives, Miralax. Occasionally, some even need a visit from our favorite superhero, the Fleet's Eneman. But that's usually reserved only for the most resistant of constipation cases. Antibiotic prophylaxis: if a child is having frequent recurrent urinary tract infections, sometimes it's really hard to gain a relaxed mode of urinating, because as they start to get better, they get another infection and it sets them back a bit. So frequently we'll recommend for a 3 to 6 month period suppression of infections so they can gain control over relaxed voiding and coordinated voiding, and then back off on the antibiotics once they're achieved kind of a nice bell-shaped pattern on a uroflow, if we're doing it in the urology office. Anticholinergics: these are typical medicines like Ditropan or Detrol, and they help to relax that thickened, irritable bladder muscle. Again, I always explain to children that and parents, this is not a lifelong therapy, as you might see with some of these medications advertised on TV for the elderly. Theirs is a neurologic deterioration of the bladder, but in children, things are very plastic. We can relearn behaviors. So we're looking at usually a 3 to 6 month trial on a medication like that. When they've achieved healthy habits, we start to back off on those medications. Also, eliminating bladder stimulants is important. Caffeine is one of the biggest ones. Behavior modification: and those that can't really gain an appreciation for relaxation of the pelvic floor, we can either do through occupational therapy, through coming in and using our complex urodynamics equipment, or some of these pictured home devices where you put little patch electrodes around the pelvic floor, and the simple device has green lights when the muscles are relaxed. They turn red when the muscles are tense. And as they're trying to urinate, what they want to do is learn how to keep it in the green so that they relax and get everything out. Usually, if they wanted to rent one of these or purchase one of these devices, we always have them come into the office first to train with us on how to use it. And then this is something that they can use as reinforcement every day at home. On some of the other additional management strategies for dysfunctional voiding, if there are significant psychosocial stressors, might need to consider psychotherapy as an adjuvant. Hypnotherapy has proven very effective in some children for both primary nocturnal enuresis and also daytime incontinence. And then in the very rare situations where someone has very, very significant infections, is spiraling into renal failure, that's when we really have to just totally put the bladder at rest, let them recover their renal function, and then go and stop what was putting the bladder at rest. And this could be paralyzing the bladder and starting intermittent catheterization. Could even be in younger kids doing a vesicostomy, letting them revert back to diapers for a period of a year, gain improvement in their renal status, and then close a vesicostomy. But these are the pretty rare cases. And I would say with a very active 25-year history of pediatric urology, I've needed to do things like this maybe 3 to 5 times in my entire career. So they're not the standard approach, but there are things that we just need to always keep in the back of our head. So I think with that primer on some of the things that we do for dysfunctional voiding, I'm going to turn things over to Sarah so that she can go through some of the cases with you.
Okay, thank you. So our first patient is Miss IB. She's an 8-year-old female with history of daytime incontinence, otherwise a healthy, precocious young woman. She potty trained without any issues when she was around 2, and previously was dry. Kind of when she was in preschool in a more structured environment, she was dry, but she started having accidents in kindergarten. Next slide. So we'll pause for a second and let you think about what you would ask, what information you want to know. And we can go to the next slide, and there's some ideas of questions to ask. But basically, we'd be doing a voiding history. We want to know when she's peeing, when are the accidents happening? Like, are they happening at school, or are they happening at at home. And these are the yellows, the answers for her. So she's only voiding when she wakes up in the morning. She tries her darndest not to pee at school, and then she's peeing when she goes to bed or before bed. And she's having accidents once to up to multiple times per day during her school day. She is not constipated, pretty regular stooling, but as Dr. Kennedy mentioned, stooling can be an issue, so something we definitely want to ask. She doesn't know what she's drinking or when, because she's drinking from the water fountain, which is also known as she's probably not drinking that much. And this is a kid with serious FOMO, so she is able to stay dry when she's at home or when she's really structured with her family, but at school and kind of left to her own devices, she is having accidents. And she rushes, she has some urgency, some frequency while at home, probably from the withholding during the day. So this is a family where the kid doesn't really care. The mom is very frustrated because she's tried everything. So go ahead and go to the next slide. Her physical exam is essentially normal. She's kind of withdrawn. She's not very interested in your visit, but otherwise everything else is normal. And you can move on. So my first question to you all is, would you do imaging? And you can have a moment to kind of ponder. And the next slide is that if you're going to do imaging, what imaging would you do? And I think Robert has a poll for us if he's able to pull that up. So if you're able to vote, you're welcome to play Jeopardy here. But your questions, or your options are, you do a renal bladder ultrasound, you do a KUB, so an abdominal X-ray, you do a CT, or you do an MRI of her spine. And we can probably pull up the results here in a second, see what people thought. Yay, you guys learned something. Most people would do an ultrasound, which is what we would start with as well. And you can go ahead and close the poll. Thank you. The reason we do, you can go to the next slide. It just gives the answer. An ultrasound. And the reason we do an ultrasound is because she previously was dry, and also because she has daytime symptoms, and she's a slightly older kid. And her ultrasound shows a thickened bladder, which is indicative of long-standing kind of withholding tendencies. So her bladder is working really hard, trying to get her to go to the bathroom more, and she's ignoring those signals. You can go to the next slide. And here's her uroflow, and this is a pretty classic dysfunctional goiter where she's got kind of that staccato start-stop flow pattern and a lot of, thank you, I have Vanna helping, and a lot of activity on her EMG. So her pelvic floor is really tight. She's trying to relax. She's not relaxing, very coordinated. You can go to the next slide. So what would you all do for her? And I'll give you a moment to ponder. And we can go to the next slide where we give you some answers. So basically, we want her to be doing time voiding. We want to help her work out a schedule throughout her day, or set that tinkle timer to remind her to go to the bathroom. We want her to make sure she's pooping regularly. We want to make sure she's drinking enough to stay well hydrated and to keep her urine dilute, as concentrated urine is irritating to the bladder. And we want her to avoid some of these irritants that are known to cause bladder irritation. And you can go to the next slide. And here's her answers. This is, again, the kid with FOMO. She doesn't want to miss the ball at recess. She doesn't want to let her friends down. So despite one of the times that she's picked in her schedule as recess to go to the bathroom, she's not really going. So basically, mom at this point in this follow-up is like, well, the kid doesn't care that she's wet. And unfortunately, you can't make a kid care, but eventually they will care. And this is also a kid who's not constipated, but not really drinking much during her day. Next slide. So what else can we do for her? I'll give you a second to think of some answers. And we can go to the next slide. And one thing I have a lot of tough conversations with parents pretty frequently is it really bothers mom. It bothers mom that her kid's the kid that has accidents, but if the kid doesn't care, it's kind of hard to motivate the kid to get better. So one kind of viable option, especially if you've ruled out kind of things on ultrasound as potentially dangerous, is tabling this conversation to the point when the kid has some buy-in or some care, because they're more likely to be successful and motivated to make those changes. You can consider an anticholinergic, so something like ditropan, and you can consider something like biofeedback, which is that pelvic floor kind of OT and training. Next slide. So briefly on ditropan, I think we kind of touched on this already, but it's an anti-spasm medicine that helps work on the smooth muscle of the bladder. And what it does is it decreases the desire or the contractions of the bladder, so therefore decreases some urgency and some frequency. The big warning on this one is it can make kids feel like they can hold forever. And if they can feel like they can hold forever and they're now Superman or what have you, they are less likely to want to stick to that voiding schedule, and it can all kind of backfire on them. So we really want them to have good kind of timed voiding and stooling down. And we also want to monitor for side effects. Next slide. So ditropan comes in liquid. It tastes really bad, so most kids don't like it, but it is available that way. And then it comes in an extended release tablet. The tablet works better because it's kind of extended release, so gradually dosed out throughout the day. So this is often a way we can get kids motivated to learn to swallow a pill, is because they want to take this medication. And we recommend that if you're going to use medication, that you follow for side effects. A very common side effect is constipation, and kids who are constipated are going to make their voiding symptoms worse. So we really want to be mindful of that and have a low threshold for treating constipation should it come up. Next slide. So if there's any questions, you could enter them in the Q&A about her, but I think if not, we'll move on to case number 2. And case 2 is an 18-year-old young woman who we followed in urology for a number of years for recurrent UTIs, as well as a patent urachus, so urachal cyst. But over the past year and a half, she's had worsening symptoms. Most of her symptoms are kind of neurologic in nature. So she has weakness in her legs, some difficulty walking. She's also had some new onset numbness in her feet and a reduced sensation in her bladder. She's otherwise healthy. I think she had a distant past history of a concussion, but otherwise an unremarkable past medical history. Next slide. So I'll give you a moment to kind of consider what you want to know and what your questions would be for her. She's a young adult, so she can probably answer these questions herself. Next slide. So we want to know, kind of, since she has this new onset symptoms, how have they changed? How have they progressed? Have things made them better or worse? Since we're urology, we also want to know, obviously, about her voiding. So has she had any daytime symptoms, incontinence, urgency or frequency? We want to know what her stools are like. Is she constipated, or is she able to go pretty regularly? We want to know if there's a pattern to her symptoms, or if it's, only at certain times of the day or only certain times of the week, et cetera. And we want to know if the family's tried anything to kind of address these symptoms. And next slide. So her symptoms have worsened. This is a kid who was on the crew team and competitive in, varsity level sports. And she came to her follow-up visit in a wheelchair, which was obviously a big red flag for us. She's unsure what makes things kind of better or worse. She just says that, symptoms are pretty constant. She isn't having pain, but she is having frequent UTIs or urine infections. She's occasionally having accidents, and she is constipated. So those are some things that came up in her history taking. Next slide. So would you do imaging? And I think we could all agree we'll probably do imaging. Let's see what imaging you guys would want to start with. You can go ahead and select your answers. So an ultrasound, a KUB, a CT, or an MRI. An MRI specifically of her spine. I'll give you a minute to answer. We can pop up the answers. Great. So most people are saying an MRI the spine, which is where we started. I think the honest answer is you could probably do, all of the above, but we started with an MRI for spine because we're concerned by the neurologic symptoms and progression. So surprisingly, her MRI was reportedly normal. She had no discrete tethered cord. She did have a terminal fatty phylum, which is a pretty nonspecific and kind of common finding, and it can be normal, but it also could be seen in kids with tethered cord syndrome. So multiple people were consulted at multiple different institutions, honestly, across the US, and most recommended, actually all 3 of these recommended continuing monitoring. Next slide. But given her worsening symptoms, we actually decided to move forward with more comprehensive urodynamics testing. Next. So urodynamics is really scary. It freaks kids out. It involves a bladder catheter. It involves a rectal tube. It involves a bunch of patches and stickers kind of in the perineal area. So this is not something we take lightly. It's not something we're doing on everyone. You can go to the next slide because it's a full contact sport. Kids are pretty combative to this, especially younger kids. They understandably don't like tubes being placed places, but it's something that gives us great information should we do it. So it gives us on the left, you see kind of a printout of how the bladder is contracting, how it's emptying, what the flow rate is, et cetera. And then we also get on the right, you see sentinel events and kind of a printout of kind of the different information that's learned. You can go to the next slide. So in our specific case, this patient had a very large bladder capacity. It was extensive. And she was at safe pressures though, which is great. Up until really high volume, she was able to hold in a safe manner. Anything under 30 cm of water pressure is considered kind of a safe point, and kind of above that starts to get into potentially higher pressure system that can impact the kidneys. She did show detrusor overactivity as well as dyssynergy with her sphincter. So those are kind of classic findings for tethered cord, as is very large post-void residual. So she had, over 675 left after she attempted to empty. So these findings, coupled with her presentation and her symptoms, is consistent with the tethered cord. Go to the next slide. So she underwent detethering. That surgery was done here at Stanford. Initially, to get through the spinal shock period, we do a clean intermittent catheterization kind of protocol to help kids empty safely. And then as they hopefully regain the ability to volitionally void, we monitor with imaging, non-invasive imaging with ultrasound to make sure that we're keeping the bladder in a safe space. Next slide. I think we're moving on. If there's questions, you can go ahead and enter them in the chat.
Great. What I'll do is a little primer on primary nocturnal enuresis, and then we'll go back to some more of the cases for Sarah to present to try to bring to light some of the information that we impart in this first part. Well, primary nocturnal enuresis is the involuntary nocturnal voiding of urine beyond the age of anticipated control. And for most people, the time in life where nocturnal enuresis starts to bother them is about 7 years of age. We notice that there's a spontaneous resolution rate of about 15% per year. Nocturnal enuresis is also 50% more common in boys than girls, and that children who actually finally gain control can often have relapses as much as 25% of the time. Why is it 7 years of age that it starts to become a problem for them? Well, if we look at the rate of primary nocturnal enuresis, you see that at age 4, which is where most people are starting to gain control, we're at a rate of about 30%. But at age 6, you become the 10% of the population. So at a sleepover of 10 kids, you're the only one who's wearing pull-ups, and that's going to keep you from doing these things in a pre-COVID world. I mean, now lots of kids aren't bothered by things. And by age 18, we're down to 1%. That 1% generally goes away when they go to college. I've sent many children to college with a DDAVP or a therapy, and they come back after the first semester, and none of them are using it because their lifestyles have changed so much and they're up so late and they sleep so little that bedwetting is a problem of the past. Well, what causes nocturnal enuresis? There are tons of different theories. And I think whenever there are tons of different theories, it means that there's no one that is the true key to it. But we'll go over a couple of things that I usually share with parents when we're talking about a consult for primary nocturnal enuresis. I usually explain to them there are 3 things that need to happen for a child to be dry at night. One is that you achieve more of an adult arousal threshold. So that means a lightened sort of sleep so that you can feel or perceive the bladder being full and get up and respond to it. The other is that you need to concentrate the urine enough so that you don't overfill the bladder. And that is something that a mature pattern of vasopressin secretion achieves. And then the last is that the bladder just has to grow as the rest of the body so that you get to the point of it having a capacity to last through the evening. And when all 3 of these things sort of meet in unison and overlap, we finally get our dry nights. The bladder capacity issue, I always tell parents, do nothing. If we do absolutely nothing and just wait it out, the bladder is going to grow with the body, and at some point they will be dry at night. For the urinary concentration, this is where you could intervene with something like DDAVP, which is actually something that will help concentrate the urine more at night so that they can reduce the volume and hopefully make it to the morning hours without having a wet episode. And then the other is the arousal threshold. We can actually do nothing and people will lighten up their sleep naturally over time, or we could impact on the arousal threshold by some of those behavioral techniques with the monitor systems, the wetness, dryness alarms. For bladder capacity, there have been some theories in the past that maybe you can stretch the bladder out during the day, but we just need to kind of keep in mind how old the child is, and we can figure out their relative bladder capacity based on that. And then with the voiding diary during the day, we can see if they're achieving that to understand if the capacity is the issue for them. Frequently, we can try to stretch the bladder, but still, if you stretch it during the day, it will often backfire on you and you'll start to develop some of those dysfunctional tendencies. And sleep patterns, there's been a lot of research because of the wetness occurring during sleep. Does it relate to a particular stage of sleep? Is it related to an underlying sleep problem? But really, it all comes down to that arousal threshold. And most parents will share with you very easily, everyone in the house can be awake. There can be a party going on, television's going, noises outside, a parade going by, and the child still won't wake up. They will just sleep through everything. Nocturnal urinary production, we frequently see a circadian rhythm to the secretion of vasopressin, and this is to allow you to conserve water in the evening. And the vasopressin works on the renal tubules to reabsorb water. And what they've noticed in children with nocturnal enuresis is that a certain subset have not yet achieved or lack that diurnal secretion. So if this is the child with that particular problem, the nocturnal urine production is going to exceed the functional capacity, and that's where you have a wet episode. Hereditary factors, there definitely is something there. I don't think anyone's gotten the Nobel Prize for a gene related to bedwetting, but you can see that if both parents were bedwetters, their child is in the 77th percentile for likely to have bedwetting. And you can see siblings also influence that, and twins frequently will be enuretic to about the same age as well. So the goal of our evaluation with children with nocturnal enuresis is to do enough testing to figure out who is totally well and has no other factor that's impacting on this. And the simple way to go about this is a medical history, physical exam, and urine analysis. And some of the things that come up in our negative screening for primary nocturnal enuresis is that they're prepubertal age, enuresis has been lifelong, the wetting only occurs during night, and during the daytime, there are really no symptoms of wetting. And if we're getting that kind of history, we know we're in this category of primary nocturnal enuresis, and we can start to move ahead without much more of an evaluation. We want to make sure that they have no urinary tract infections. We want to test with a urine analysis to make sure that that's the case. And we want to do a detailed physical exam looking for the region of the lumbosacral spine to make sure that we don't have sacral dimples or other neurologic problems. If we do have neurologic issues that show up on exams, this is a child that we need to refer to the specialists in those categories. If it's a sacral dimple, the neurosurgeons. If it's something to do with the bladder or the renal production of urine, maybe to the nephrologists. Other things that would be common reasons to refer someone with nocturnal enuresis to a specialist would be if they have painful urination, rectal pain, vaginal or penile pain and discharge, or straining to urinate. These signify things that are more dysfunctional about their voiding and not usually associated with just primary nocturnal enuresis. Patient treatment, there are multiple modalities to treat people with nocturnal enuresis, but as Sarah pointed out before with the dysfunctional avoiders, sometimes we have to know what the parents are after. A lot of them just want confirmation that their child is totally fine and not want to go ahead with any treatment, and others really want to embark on treatment. The treatment strategies for nocturnal enuresis are going to be either drug-based or behavior modification-based. And most parents usually elect to go with behavior modification first. Very few want to jump right into medications unless they come in with a very short timeline for something that they want to achieve. And frequently we'll get the person who comes in and says, I leave for summer camp in 2 weeks and I want to be dry. And in that situation, we might resort to a medication therapy right at the beginning to get them through the summer camp, that's to keep them dry. And then when they come back, work more on behavior modification and scale back on the medication portion of the therapy. Expectations are high here when we are thinking about nocturnal enuresis. And sometimes the physician's expectation or the provider's expectation is not the same as the parents. And when they've done surveys to check this out, physicians 90% of the time think that the parent brings it up because they want treatment, and only 63% of the time do the parents actually want treatment. Most of the time they want confirmation that there's not something anatomically wrong with their child that requires more evaluation. And if everything is fine and this is just a standard problem they're going to outgrow, many parents will just sit back and wait it out another year or two for that to happen. Some of the pharmacologic treatments that have been out there, I bring up the imipramine because a lot of people might remember that if you're old school like I am. It was not a very useful medication, had very poor response rates and had lots of side effects. So this has become something that we don't commonly use very much. DDAVP has become the medication of choice for primary nocturnal enuresis. And as we pointed out before, it's actually to try to reduce the amount of urine that a child is making in the evening to stay dry for the period of time that they're sleeping. Responders tend to be characterized by having nocturnal polyuria, and responders that are very successful usually have a larger functional bladder capacity. The non-responders tend to be the children that already concentrate their urine very well or have a normal circadian variation of vasopressin. And the reason why we know that is because of the studies that were done to show efficacy of it. We don't really plot anyone's circadian vasopressin secretions to find out if they're going to be a responder or not. Another characteristic hallmark of those who have failed with DDAVP are those that have an exceptionally small bladder capacity, because even if you go ahead and reduce the volume, the capacity is still small, and you need to wait for that to enlarge before they can actually successfully stay dry. Just a few pointers on administration. We used to have nasal spray and tablets. Nasal spray is still available, but it's not indicated for primary nocturnal enuresis as a first-line therapy now because of the higher risk for hyponatremia and water intoxication. So we typically go ahead with tablets, and the tablets are, the dose range would be anywhere from 0.2 to 0.6, and you can see the tablet sizes down below. The nasal spray and the tablets need to be titrated to the correct level as well for the child. And Sarah will go over that in one of the case presentations. And we consider behavior modification our first line therapy. And what we want to do is train the bladder. We want to reinforce responsible behavior. And sometimes we want to use the urinary alarm systems. And it's generally a combination of these things that gets us dry at night from the behavioral training point of view. As I mentioned, some people have the theory that, well, if you stretch the bladder during the day, you're going to have a bigger bladder at night. You have to be careful with that because you can so stretch it during the day that then you start to develop dysfunctional tendencies and irritability of the bladder. So you exchange one type of nighttime wetness for a different type of nighttime wetness. So we shy away from this and we just generally wait for the bladder to grow on its own. Responsibility reinforcement is where we need to motivate the child. And that's the gold star charts to show that they're complying with some of the things that they can do. Fluid restriction is one of the big ones, and here, based on their weight, and kind of suggesting from an article that was out there, what's a reasonable amount of fluid to drink before they go to bed, between dinner and bedtime, so that when you void right before going to bed, you're sure that you're going to eliminate that fluid and be able to start with an empty bladder and small production to start the night. Again, responsible voiding during the day is helpful because that minimizes the irritability and overactivity of the bladder, making sure that it's quite quiet and comfortable during the night when you're trying to fill it. Conditioning therapy, these are your bed alarm pads, and these work extremely well. The difficulty is that they take a long time to actually work. Frequently, you'll hear from parents that they've tried the bed alarm system, but it didn't work after a month, so they gave up on it, or it woke up everyone else in the house and the child still didn't wake up, and so they gave up on it because it was impossible to get to work the next day or school for all the other tired children in the household. Basically, if you do use the bed alarm system, what you want to make sure is that it has a couple of ways of trying to wake up the child. So successful ones not only make noise, but often have the device that clips on to their undershirt or pajama top so that it vibrates at the same time, so that both stimulation from the vibration and the noise work out to help them wake up in the evening. Outcomes for this can cure enuresis 60 to 100% of the time, but you relapse about 25% of the time after you stop using the device. I had one parent once who had the best way of using a bed alarm system. The bed alarm system didn't awake the child at night, but it just made the family dog howl so much that they locked the family dog in the room with the child at nighttime when they were sleeping. And when the alarm went off, the dog started howling, jumped on the bed, licked the child, and that ultimately got them up. So it was a combination therapy, and the family dog earned its treats in the morning. With that, I think we'll turn it over to Sarah to go through some of the case studies, and then we'll kind of save some time at the end to get some of the questions that we weren't able to answer in the didactic portion.
Great, thanks. So our next case is a 13-year-old young man with primary nocturnal enuresis. He's otherwise healthy, no significant past history. He potty trained for the daytime without any issues at around age 3, so at an age-appropriate time. And he denies any current daytime symptoms right now. He has no, dysuria or frequency. He's dry during the day. He's not getting infections. Next slide. So I'll give you a moment to ponder kind of what you want to ask him and, what we'll address in our history taking. And we can go to the next slide. So we basically want to know similar things as our earlier cases, but also a specific emphasis on kind of the nighttime and evening. So we want to know what his daytime habits are, as that will affect his nights. We want to know when he's drinking, what he's drinking, how much he's drinking, etc. We want to see if the family or the patient has a pattern to when he's wet. Is it always at a certain point in the night, or is it multiple times a night? Or different variations like that. We want to know if there's any daytime symptoms. We want to know if there's a family history of bedwetting, as that can obviously contribute. And we want to know what the family has tried, if anything, when they come to your visit. Next slide. Are some of his answers. Sorry, this is a really busy slide, but the take home here is his daytime is actually pretty good. This is not his first visit with someone for this concern, so he's got a pretty good cadence of voiding during the day. Some areas, though, that we can work on is he is fluid loading in the evening hours because he's a very competitive basketball player. So he's got his practice and his games in the after school and evening hours. So he's drinking a fair amount then. Family says he sleeps like the dead, so he's never waking up. He just wakes up soaked, and he wakes up soaked every day, despite what they've tried. He does have a family history, so that's something to consider. And family feels like they've tried everything. We've tried alarms and they didn't work because it woke everyone else up. We tried limiting fluids, but it was too hard to do. We've tried medication. Next slide. Now, his physical exam is normal, so we don't have to go through all of this. He's kind of a mid-pubertal male, otherwise normal exam. Next. So would you image? And if so, with what? You can do the poll. So would you do an ultrasound? Would you do a KUB? Would you do a CT? Would you do an MRI? And we can probably go ahead and show those if people have voted yet. So most people would do an ultrasound. I think it's, and that's what we would start with. I think a KUB is very reasonable as well, though, just to see if there's constipation they're not picking up on. So you can go to the next. This is just an ultrasound example. This is a normal bladder that's not full, but it's not trabeculated, it's not thickened. Next, right kidney is normal, there's no hydronephrosis. And the left is also normal. Nice, beautiful kidney, no hydronephrosis. So he had a normal imaging. So what would you recommend? Exactly. We do some regular voiding. We want to make sure the daytime habits are good. We want to have a low threshold to treat any constipation so you don't have that pressure on the bladder. A big one for him was shifting fluids earlier in the day and really working with him to invert that pyramid. So he wasn't drinking the most of his fluids at night, but rather trying to drink them during the day when he's awake. You can go to the next slide. I think it has the answers. Exactly. We want him to avoid that Gatorade because it is a known bladder irritant, and that might be triggering some symptoms. And this family was frustrated. They've gone to multiple specialists for this. They've seen their pediatrician multiple times, so they decided they did want to try a medication again. Next slide. So as was mentioned earlier, DDAVP or desmopressin is kind of the gold standard or the go-to medication if you're going to use medication management. And what it does is it is a synthetic version of vasopressin, and it basically decreases urine volume. So it's not magic. It's not going to make the bladder bigger. It's not going to make kids wake up overnight, but it does make them make less volume. Go to the next slide. So it comes in two tablets, either a 0.1 or 0.2 milligram. And you can dose it in kind of a range between, generally it's between 0.2 and 0.6 milligrams. Kind of often something we will do in our practice is start at the higher dosing. So start at 0.4 or 0.6, just to see if it works. And if it works for that kid, fantastic. Then you know it may be a concentration, at least as a component, concentration issue. And you can titrate down to get to the lowest effective dose where they can stay. But this way you don't have to spend weeks of kind of titrating up medication and kids getting frustrated and kind of burning out and stopping before they even get to their therapeutic dosing. One kind of caveat here is generally this is used for social things. It's used for the sleepovers or camp, etc., going on family vacation. But if some kids want to use it for their own psychological, psychosocial benefit, they use it every night. And if they are going to use it at higher doses, we do recommend at least monitoring one time with Chem 7 or a metabolic panel, just to make sure that we're not affecting the electrolytes. Next slide. So our last case study, and then we can go ahead and wrap up here, is a 4-year-old young woman who was antenatally diagnosed with a duplicated left kidney. And otherwise, she's a healthy, kind of precocious kid. She potty trained or started potty training, attempted to potty train at around age 2. But despite good efforts, she's constantly wet. She had a negative VCUG as a baby that was done because of the antenatal history, and she's having no UTIs. Next. So what would you want to know about her? Next slide. So these are kind of the similar questions we were asking for everyone. We want to know when they're going to the bathroom, what they've tried, have they noticed any pattern to the symptoms? Next slide. And her answers are, she's got actually a pretty good time schedule. She's probably peeing more than the average kid, and I think it was because they were attempting to get her dry. And despite her regular bathroom intervals, she was constantly wet. She was wet despite having just used the restroom. She's not constipated. She's drinking pretty well. And family doesn't notice a pattern. They say she's always wet, so they don't know what makes things better or worse. The kid's the one that's kind of driving this. She's frustrated that she's trying really hard and can't be dry like her friends, but her parents are pretty supportive. They're not overly frustrated. Next slide. The kind of highlighted point here on her physical exam, besides the fact that she came in a ball gown and skinny jeans, is that on her GU exam, she has immediate dampness noted kind of in the perineal area. It's unclear where the urine is coming from, but there's definitely pooling urine in real time. Next slide. So would you image? And if so, with what? And I will go ahead and let you vote. Ultrasound, X-ray, CT, or MRI of the spine. And we can probably get the answers in the interest of time. And so most people, it's pretty split here, said they'd start with an ultrasound. A lot also said they would do a CT. You can go ahead and close that. So we usually start with ultrasound because it's a good screening mechanism. It's cheap, it's effective, it's non-radiating, and there's no kind of internalization, et cetera. It's just a picture. So we started with an ultrasound, but I think one reasonably could have done a CT or an MRI, just this would be less invasive. And as you can see with the arrows here, she does have the ectopic upper pole with some cysts in it, and that was again identified prenatally. You can go to the next slide. But what we also have is a dilated ureter coming from that upper portion of the left kidney. Go ahead and go to the next. So what would we do? And you could say phone a friend, you'd go to the urologist. Exactly. So she likely has an ectopic left upper pole ureter. And most likely this is outside of the bladder, which is why she's wet. So one could do an MRI of the abdomen pelvis. That would give us a better sense of her anatomy, but it likely would require an anesthesia in a kid her age. So what we suggested to the family and recommended was that we just limit to one anesthesia and do an exam under that anesthetic, do a pilogram, and then should a ureter be identified outside of the bladder, we could reimplant that and fix it at the same time. So you can go to the next slide. So this is her retrograde. So this is done through the bladder. It goes into the ureter, and dye or contrast is inserted in, and this is a pretty normal picture. But then the next slide shows she, on careful inspection, had kind of a small punctate opening in the hymenal ring, which was cannulated and some contrast was inserted or injected in, and she has the secondary ureter that goes up. So she did have an ectopic ureter, and this is a picture of that. So you see there, once you're in the bladder, she has basically, or outside the bladder, I'm sorry, you have a Foley going in through the urethra, which is that pink on the top, and then you have kind of the bluer cannulation of her secondary or accessory ureter. And right below that's the vaginal opening. So you can go to the next slide. So she underwent reimplantation, and this was a very satisfying procedure because she woke up dry, which is a good thing to end on. Next slide.
So just a quick slide there to show you all the members of our team. Sarah and I obviously treat a lot of folks with Eneresis, but so does the rest of the team. They're all expert. It's probably one of the most common consults we get. With that, why don't we move ahead to our questions and answers? And maybe we shouldn't ask them to hold, is the bottom line. And while we're kind of going over questions and answers, I'll leave a shameless plug for a happy, healthy bladder study that one of my colleagues is doing. And if anyone has interest in that, you can scan her QR code and read up more about what she's seeking to do in the realm of Euresis. Well, let's go to our Q&As, and why don't we start with the first one, which says, what is the significance of a thickened bladder wall on ultrasound and dysfunctional voiding? I think that one was asked early in the presentation, but we did mention that the thickened wall is a more hypertrophied and irritable muscle, and frequently behavior modification alone is going to take a long time to work, and sometimes speeding up the improvement in their symptoms by adding an anticholinergic helps out. What is vaginal voiding? Do you want to take that, Sarah?
Sure. So it's when urine, if a kid has tight pelvic floor and kind of their legs are crossed and they inefficiently get urine out from the urethra, they can kind of pool some urine in the vagina. And so when they stand up and start to walk, they often will kind of dribble that out.
I've got an excellent question here, which Sarah has to deal with every day of the week. What is the best way to approach time voiding schedule during school hours with teachers, many of them who limit access for going to the bathroom? Any tricks there, Sarah?
Yeah, so I always give a shameless plug. I was a teacher in my past life, so I sympathize with teachers wanting their kids in class during class. We try to focus with kids to try to find a time to go to the bathroom they have natural cadences broken up into their day. They have a recess in the morning, they have lunchtime, they have snack recess in the afternoon, etc. So in a perfect world, they'd be going kind of at those intervals and then additional times as needed. But sometimes we will write letters for school or to teachers, et cetera, to try to give them extra nudging to go to the bathroom, or give them a 2-minute head start to recess so the kid can get out there and get to the bathroom before, so they don't miss out too much. But it's a balancing act.
I have a question here, which has a couple of parts to it. Maybe we can share some words of wisdom. And it says, is there a way to determine at home if nighttime voiding, which occurs, which appears to be a staccato-like release, is of concern or requires testing? For this young female, first morning void appears to be in small amounts, and much of it is dribbling. If well hydrated, what is the typical amount of urine on a first morning void? Well, typical amount of urine on a first morning void, if a child stayed dry all night long, is going to be roughly what their bladder capacity is, because you kind of just about get to that, and then you would have a wet episode. So if you're doing a voiding schedule during the day and find out that roughly their capacity is about 200, the first morning void would be about 200. Be a lot darker yellow color because it's going to be concentrated, versus during the day might be a little bit more light yellow to clear. I find one of the best questions that I can ask a parent of a child who's wet at nighttime to try to differentiate, is this primary nocturnal enuresis, or is this a dysfunctional voiding manifestation, is to say, if you checked your child, assuming that you put them to bed at a reasonable bedtime of 9 o'clock, before you went to bed at 11:30 after the news, would you find them wet at that time? And if they answer yes, that usually is a dysfunctional voider with overactive bladder. If they say no, they're totally dry every time I check them at that time, and it seems like they're getting wet more like 4 o'clock in the morning, 5 o'clock in the morning, that's usually our primary nocturnal enuresis pattern, because they have a normal function to their bladder, and it's only when they get to the capacity that they finally void. It's the irritable overactive bladder that you can go to bed and 20 minutes later can be wet because your bladder squeezes, and now because you can't tighten your sphincter because you're sleeping, the wetness happens. So I find that is a good way to try to differentiate them if you had a simple home test to do with the parents. Another question here, which is excellent point to bring up, more a statement than a question. Notice that you did not mention sexual abuse as a factor. Definitely the case. Usually not for primary nocturnal enuresis, but if you have secondary enuresis in a child, daytime wetting, you always want to keep that in mind as a potential in the social factors that you're going over. Let's see what other questions we have here. Why is Gatorade irritating? Do you want to answer that one, Sarah?
Sure. So Gatorade, first of all, is a fair amount of sugar. And secondly, the artificial dyes can be an irritant to the bladder. So the neon red, neon green, non-naturally occurring colors are irritating to some people.
Great question here. What kids benefit from hypnotherapy? Is it only kids with primary nocturnal enuresis? What are the components of medical hypnotherapy for enuresis? We actually always, for primary nocturnal enuresis, put that on the list of options for children and parents to choose. Most of them like to go with simple behavior modification, the restrictions of fluids. If they're in a rush, they usually like to go the medication route. I find that most of the parents, if they've tried the medication and they fail, that's where they want to engage in hypnotherapy, even though we've offered it from the start. And then does hypnotherapy have an effect for all types of enuresis? I've had some people who have been with dysfunctional voiding, and medical hypnosis has helped them out as well. I know we have an expert in the audience, Jeff Lazarus. I don't know if Jeff is there. Do you want to add anything? Maybe we can promote you to a panelist member for a moment to get some of your thoughts on medical hypnotherapy. Oh, maybe Jeff isn't there. All right, well, there's a great person in our community, if you're living in the Bay Area, Jeff Lazarus, who is who we usually refer to for medical hypnotherapy, and he does a great job with kids.
Hello.
Oh, you're there. Okay, great.
Hi, Bill. Hi, Sarah. Great lecture, really comprehensive in such a short period of time. Yeah, so medical hypnosis has been shown to be helpful, particularly for primary nocturnal uresis, also for secondary nocturnal uresis. You want to make sure that it's all that whatever appropriate studies need to be done are done. And there's a study that was done by the Division of Pediatric Urology at Dornbecker Children's Hospital, Oregon Health and Science University, using a home video program that was shown to be that was equal to in efficacy to the alarm and to medication, not better, not worse. So that study is yet to be published. And what's nice about it, Aaron Bain is the principal investigator of that study. As he says, when it's, hypnosis takes some work. It's not give me the quick pill. It's not a quick fix. It involves some work on the part of the child, but it's very empowering. And as Aaron said, he's going to write in this paper, the urologist at Dornbecker Children's Hospital in Portland, he likes the hypnosis program because it gives it's empowering rather than say, hey, I did it on my own without taking medicine, without using the alarm. So, and yeah, I see patients all the time and here and also across the states. So also, as Bill, as you know, we've shared patients with overactive bladder as well who've done well. And there's been literature to support hypnosis for that as well. Thank you for allowing me to participate in this thing. And it was a great lecture. Thank you so much.
Thanks, Jeff, for those words of wisdom and insights. I think we had a question here who obviously is one of our urologists in the audience that wants to know why not an upper pole heminephrectomy for the ectopic ureter. And that certainly is one way of dealing with it. You can go ahead and just remove that segment of the kidney and go straight down to the base and take the ureter out as well. In the past, this would be an extraordinarily invasive surgery. So doing a reimplantation of the ureter, which is a lower end surgery, was less visible, less uncomfortable. But nowadays with robotics and laparoscopic techniques, doing an upper pole heminephrectomy might be a very reasonable way to treat that ectopic upper pole ureter as well. Let's see, we've got a couple more minutes and go down the question list. How long can one use DDAVP? And when do you check electrolytes, and how do you wean them off of it? Fantastic questions. Do you want to take a stab at some of those, Sarah?
Sorry, I'm typing answers into other questions.
Oh, okay. Well, then I'll let you finish typing there and I'll take a stab at this one.
Cool,
so
sorry.
DDAVP is something that you can use indefinitely if you want to, and some of the older kids continue to use it. When we're on 4 micrograms and above, we generally in that situation will, after a month of continuous therapy, check the electrolytes on them to make sure that we haven't had any pronounced effects. When you're using DDAVP, we typically at the start, especially in the younger children, recommend a holiday from the medication for a weekend once about every 4 months. And if they stop it on a Friday night and they stay dry Friday, Saturday, Sunday, we say to continue off of it. If they are immediately wet, we put them back on it. With the older kids that we start, we generally tell them twice a year to do the check to see if they need the DDAVP. Honestly, some of them just every now and then forget to take the medicine and they know really well, oh, I forgot it tonight, and they were wet the next morning. So they're getting their continual feedback about things. But as Sarah pointed out, DDAVP doesn't improve anything for you. It keeps you dry. You still have to wait for your arousal threshold to change or your bladder capacity to get big enough. And if your bladder capacity gets big enough, you stay dry for the night and don't need the DDAVP. If your arousal threshold lightens up, then you're just going to get up, go to the bathroom, and go back to sleep. And obviously, DDAVP is not needed. That tends to be the college student that I send off with the prescription for DDAVP. They're the ones who kind of, just because their lifestyle has changed and the arousal threshold has changed, no longer need it because they get up and go when they need to. Let's see. Do you have any pearls when coaching parents on how to use a bed alarm system?
That's the one I was just typing in.
Okay.
And my answer was patience, consistent usage. The reason alarms don't work is because everyone stops using them before they have time to be effective. Because as was mentioned, they take a long time, up to 4 to 6+ months of continuous use on, kind of the extreme, but at least a month or more of continuous every night using them. And most families stop using them before they get to the therapeutic kind of response.
When I meet the frustrated family with the bed alarm, that's when I share my story about the family who got the dog and put them in the room with the child. And a couple of families have taken me up on that and have had equal success. So family pets can be involved in therapy too. I guess that would qualify your dog as a service dog as well.
Fair.
Special airplane privileges. Last question, what is a urachal cyst? A urachal cyst was an incidental finding on that patient, and it's a remnant of the bladder communication through the umbilicus that was present during the development period of the bladder, and it generally involutes and goes away. They do have a higher incidence for potentially harboring cancers in the second and third decades of life. So this was being followed incidentally and wasn't anything that was associated with the Euresis in that child. I think with that, we have hit our 1:30 time frame. So
Yes.
Thank you all for
Yeah.
attending.
Thank you so very much to Dr. Kennedy and to Sarah for just an excellent lecture on this topic. Clearly, lots of outstanding questions. And so I'll actually see if you're willing to answer some of those questions offline, and we can send an email out to the audience with your responses if that's possible. But I just want to say thank you for spending this 90 minutes with us on this topic. I also wanted to thank our attendees for this session and the first day of Children's Week, and to remind you that tomorrow we have 2 sessions, one on congenital CMV infections and hearing loss, and the afternoon on cardiac arrhythmias. So join us for that. You can still register if you haven't. And if you missed the morning session where we talked about innovations to advance pediatric health equity, we had a short showcase of some of the innovation that's happening in the Stanford community and outside. So feel free to check out some of the videos that were sent to us to highlight that. And questions about CME, you'll receive an email business day, so tomorrow. Nothing for you to do right now, but you'll receive an email from our office, and you'll be given the option to claim CME if you would like. But with that, thank you again for spending this afternoon with us, and have a great day.